And since we have our first speaker for the next symposium, What Nation Wants to Know, makes me sound like one of the journalists from a very, very leading news, news channel. And we are here today with three very, very eminent speakers. The chairpersons of this session are Dr. K.K. Parikh sir, who is an MD and senior consultant physician from Kota, Rajasthan. He has been a mentor to a lot of doctors and physicians. And the second chairperson is myself. I'm a consultant diabetologist for Rudraksh Institute of Medical Sciences from Ahmedabad. So I think Parikh sir hasn't connected yet. So can I have the pleasure of introducing our first speaker, Dr. Jiten Vora sir? RX team, okay, thank you. Thank you for the slide. Jiten sir is a professor at the University of Liverpool and is a consultant physician at the Royal Liverpool University Hospital, and he specializes in diabetes and endocrinology. He has gained his qualifications from the University of Cambridge, and he has a lot of qualifications and degrees to his name. He has ongoing research interests, which include development, screening, and treatment of diabetic retinopathy, renal hemodynamics, and hypertension in type 2 diabetes, the prevention of renal disease and diabetes, and the physiological aspects of treatment of type 2, and mechanisms of osteoporosis. He has published extensively in the field of diabetes and endocrinology and has served on many advisory panels, including the NICE guidelines. With that, Jiten sir, can I take a moment to welcome K.K. Parikh sir? He has connected with us. Parikh sir, we've just introduced our first speaker. And Namaskar sir. Sir, if we have your permission. Jiten sir, yes. Sir.
Yes, we can start. Yes.
Thank you, sir. Jiten sir, if you can share your slides now. We did see a part of your slides a minute ago.
Can you see them now?
Not yet, sir.
My screen is being shared.
So could you try once again by stop sharing once and then try and reshare the thing again? Yes, we can now see your slides, and it is in full screen.
Full screen.
Yes.
Yeah. Excellent. It's always a moment of hesitancy when you're trying to share your screen. But thank you very much. Thank you for your very kind introduction. It's always a pleasure to participate in Diabetes India, and I'm grateful for your invitation again. I'm honored, and it's a great privilege. It's a pity that we're not in Goa, but there we are, next year perhaps. So in the next few minutes, I want to emphasize on the organ benefits of SGLT2 inhibitors. The reason for this presentation or this title is that I am frequently asked the following question for patients with diabetes. And that is, who should have SGLT2s, when, and why? And so over the course of the next few moments, I would like to present some data and information and then try and answer the question at the end of the presentation. I realize that you will be seeing quite a lot about SGLT2s through the course of this meeting. So mine is an overview rather than a concentration on any specific databases. So in order to try and answer the question that I have posed, I'm going to cover SGLT2s in renal disease and heart failure as an example of the organs. But we're going to try and address potential primary prevention in people with type 2 diabetes. And then we're going to look at the delay of progression and or potentially the regression of renal disease and heart failure. And then finally, we will summarize with the findings and also try and address the initial question that we have posed. So firstly, it's not important to emphasize to an audience such as this that CKD is very common in people with type 2 diabetes. Regardless of how you measure it, and that by that I mean either eGFR and or albuminuria together, somewhere of the order of 40 to 50% of people with type 2 diabetes will develop a degree of renal disease. Those who develop renal disease have an increasing mortality, and the mortality increases with each stage of deteriorating renal function. So a development of an avoidance of development of renal disease, as well as a possible retardation, is important for these patients. Now, all of this information started off with the publication of these 4 trials, which were essentially safety trials. And you will see here the renal composite endpoints in the EMPA-REG, CANVAS, DECLARE-TIMI, and the VERTIS trials. And the remarkable thing here is the consistency in the benefit that's seen with this class of drugs. So each group, each drug in each trial demonstrated a hazard ratio of somewhere between 0.55 and 0.66. So these reduce the renal composite endpoint by somewhere of the order of 40%, absolute relative risk reduction of somewhere of the order of 40%. And it is important from this perspective that these studies, the patient population included a broad range of people with type 2 diabetes, including those who had established cardiovascular disease. The trials were enriched for cardiovascular disease. But from a renal perspective, there was a broad range of patients. So this reduction, the relative risk reduction of 40% in a broad range of patients, is very applicable to our clinical practice. So let's then move on to this potential primary prevention. Here is some data from the DECLARE-TIMI trial. And in this trial, you will remember that some 60% or so of patients did not have established cardiovascular disease and were therefore in the early spectrum of type 2 diabetes. This is exemplified by the fact that their mean eGFR was 85, and very few people had microalbuminuria. Thus, we are talking about people who did not have renal disease or were at a very early of the spectrum of renal disease. And even in this group of people, the hazard ratio was reduced to 0.53. So this, to me, means that there is an element of prevention, either in development of early or progression of early disease, by approximately 50%. So this implies that there is a degree of prevention, a primary degree of prevention of renal disease in this patient population with SGLT2 inhibitors. Likewise, if you look a little bit more closely into the data from, say, for example, here, the EMPA-REG and CANVAS population, you find that new onset of microalbuminuria, that is early abnormalities of urinary albumin excretion, or macroalbuminuria, that's established nephropathy by our previous criteria, is reduced by some 50% relative risk. So these two together mean to me that giving people SGLT2s early in their treatment for type 2 diabetes produces a degree of prevention of development of renal disease in type 2 diabetes. So it exemplifies the early use of SGLT2s in this patient population. You will also know that the renal benefits of this class, particularly in here, EMPA-REG and CANVAS and DECLARE, was seen regardless of the baseline eGFR. So here we have eGFR starting at the top with the highest eGFR, and thereafter, as we go down, the GFR is declining, and yet you will see that there is a consistent relative risk reduction of 50 to 60% in the composite renal endpoint in all of these studies. The same is true for regardless of baseline albumin-creatinine ratio. Here, we look at urinary albumin excretion rising from, as we go down from the top, we go from normal albumin excretion, increasing to abnormal albumin excretion at the bottom. And you will see that the relative risk reduction is maintained in those who had a normal albumin excretion rate to those who had a significant albumin excretion rate. So the renal risk benefit of these compounds is present regardless of your baseline renal function, regardless of whether it's measured by eGFR or by albumin-creatinine ratio. So for a renal risk in patients who do not have established renal disease, we have so far seen some data of potential primary prevention and renal benefit in any group of patients even before they develop persistent proteinuria or nephropathy. And this is also exemplified if you look here in the renal, in the albuminuria patterns in these studies. So here we have the 3 studies, DECLARE-TIMI, CANVAS, and EMPA-REG. And you will see that as we go from the top which is primary prevention. And this shows you that the level of protection that is achieved for proteinuria levels going from normal to abnormal. And you will see that there is a 1/5 reduction in patients developing abnormal proteinuria who had a normal protein excretion at the onset of the trial. So again, there is some evidence of primary prevention. If we then extend this to progression of established disease, either you have normal or microalbuminuria, which goes to macroalbuminuria or microalbuminuria, you will find somewhere of the order of 1/4 to 1/2 reduction of progression of abnormal proteinuria. And the key issue here is that there is somewhere of the order of half regression of proteinuria to the level before the level that you had at the trial's beginning. So we have evidence of delaying development of proteinuria. We have evidence of development of delaying progression of proteinuria, and we have evidence of retardation or regression of proteinuria. Now, you all know, of course, that if you want to protect the kidney, you need to either reduce or regress proteinuria levels. So again, this gives you information of potential primary prevention as well as renal benefit throughout the spectrum of renal disease in type 2 diabetes. So what we've seen so far is eGFR data, real composite endpoint data, proteinuria data that shows potential primary prevention of development of renal function in type 2 diabetes, as well as potential reduction in the progression and some regression to the level prior to the level at the start of the trial. All of this means that the kidney is protected. And you also know, of course, that if you protect the kidney, then you reduce the otherwise increasing cardiovascular mortality that is seen in patients with the development of different progressive stages of renal disease. So now let's move on very briefly to people who already have established renal disease. And here is data from the DAPA-CKD trial, showing you in patients who have a mean age of 62, a median GFR of 43, and approximately a gram a day of proteinuria. The use of dapagliflozin in this case versus placebo resulted in a hazard ratio of 0.61, meaning that there was a 40% or so relative risk reduction. And if you look at the curves, it takes approximately 8 to 12 months before these curves begin to separate, which is very different from the curves that we will see for heart failure in a moment. Now, if we specifically look at renal disease, then you will see that similar 50% or so reduction in renal risk. Now, the previous graph was a composite which included CV death. This is a figure that looks at just renal function. The differentiation between the two is important because, as you well know, majority of our patients with type 2 diabetes who develop renal disease die of cardiovascular disease even before they go on to dialysis. So the initial slide is important because it shows a reduction in cardiovascular mortality as well as renal changes. And this figure is important because it shows a 50% relative risk reduction in the progression of already established renal disease. The same was true for the Credence study using canagliflozin in people with diabetes with a mean GFR of 56, and again an albumin excretion rate of approximately a gram of proteinuria a day. And you will see again a consistent reduction of approximately 40 to 50% in the hazard ratio for the renal composite endpoint. And both the hard points of doubling of serum creatinine and end-stage renal disease demonstrated a reduction. So what does this all mean in terms of the outcome for patients with type 2 diabetes who have established renal disease? First of all, it means that we are protecting them from cardiovascular disease, so that the patients who are dying because of increased CVD, which increases as renal disease deteriorates, we are reducing their cardiovascular disease. But more importantly, we are reducing the rate of progression of renal disease. And what does that actually mean? Here you look at the modeling data of the Credence study. And what it essentially shows you is that use of credence versus placebo in this study resulted in a 15-year delay in dialysis. So if you have a patient with type 2 diabetes with established renal disease, GFR of 55, proteinuria of a gram a day, the use of an SGLT2 will delay the use of dialysis by 15 years. That has great implications for not only patient-related outcomes, but also from the perspective of cost efficiency. So let's move on now very briefly to cardiovascular outcomes. And you are, of course, all aware of these trials. Here we are summarizing some data from the four main trials, EMPA-REG, CANVAS, DECLARE, and VERITAS. And you will see, first of all, the heart failure ratio, the hospitalization for heart failure, which shows a consistent reduction in hazard ratio to approximately 0.65 and 0.7. And we're going to be looking at this data in a little bit more detail in a moment. What about CV death? Different trials with different patient populations and different primary outcomes and different statistical analysis. But you will see that empagliflozin in a group of patients who had been enriched with cardiovascular disease for the trial revealed a reduction of approximately 40% hazard ratio in CV death. The others did not show this because the patient population was very different, the analyses were different, etc. Similarly, in 3-point MACE, it's difficult to show an analysis because of the different populations. And indeed, particularly in CANVAS and DECLARE, this was not a primary statistical endpoint. It was used as an exploratory endpoint. So 3P MACEs were not used predominantly in these studies. So let's turn our attention to heart failure. Again, we go back to the four main trials, and you will see here hospitalization for heart failure in all four trials shows approximately the same 0.4, 0.35 reduction in hazard ratio. So there is somewhere of the order of 30 to 40% reduction in relative risk of hospitalization for heart failure. Now, this was for hospitalization for heart failure as a first episode, but also as a potential repeated episode. And what we're interested in from a potential primary prevention perspective is what does it do? What do these agents do if you did not have a history of heart failure? So here at the top of this figure, you will see that patients who had a pre-existent history of heart failure demonstrated a hazard ratio of around 0.7, suggesting that it reduces the risk of further episodes of heart failure. Whereas at the bottom half of this curve, of the graph, is people who did not have a history of heart failure. So they had no pre-existent heart failure. And in these patient groups, the first episode of hospitalization of heart failure was reduced by approximately 30%. So again, there is an element of quotes, organ benefit, primary prevention, in that you can stop the development or delay the onset of the first episode of hospitalization of heart failure. Now, people have frequently questioned what the hospitalization for heart failure means, particularly the first episode. We have to remember here that in groups of patients that we are studying who do not have pre-existent heart failure, unless we are constantly looking at BNPs and echocardiograms, the first episode of hospitalization of heart failure is used as a surrogate for the first episode of heart failure. So this time to first heart failure is important. And here we have all the big trials with SGLT2s, and we're looking at the time to the development of first episode of hospitalization for heart failure. And you will see a consistent benefit with a relative risk reduction of approximately 40% in the time to first heart failure. And again, this gives you an idea, an emphasis on potential prevention of the development of heart failure or potential delay in the development of first episode of heart failure. So far we've seen data from the four main trials of prevention of hospitalization for heart failure in a broad range of population of type 2 diabetes. We've then seen some data that the time to and the occurrence of the first episode of heart failure is prevented in all of these patients. So what about people who already have pre-existent heart failure? And here I'm summarizing the data from the two big trials, the Emperor Reduced with empagliflozin and DAPA heart failure with dapagliflozin. And you will see a consistency in the results. And you will see that at the top half, particularly for this presentation, in patients with diabetes, there is a 25% relative risk reduction in people who have established heart failure in the development of next episode of heart failure or the development of CV death. So here we're looking at the composite of CV death and hospitalization for heart failure. A consistent result in both those main trials showing you a reduction of approximately 25%. This information is present in patients with diabetes, and the result is consistent in people without diabetes, which gives the whole physiological basis for the treatment credibility. The benefit is seen in people with diabetes with or without eGFR reduction. The other component of these trials that's important to recognize is what happens to renal function in the heart failure trials. Now, we're all aware of the fact that in patients with heart failure, declining renal function is seen frequently, which limits therapy. The reverse is also true, which is in patients with renal disease, we see heart failure frequently. But here what we are seeing is the data in hospitalization for heart failure in patients who already had established HFrEF. And here we can see an approximately 30 to 50% relative risk reduction in the development of a renal composite endpoint in a heart failure trial, in a HFrEF trial. So the renal benefits that we saw earlier in my presentation is also maintained in patients who were in the trial, in a heart failure trial. And this would mean that you would be able to continue the therapy in more patients because you have reduced the development of a persistent decline in GFR, a sustained decline in GFR. So again, we have evidence of, in this group of patients with heart failure, and evidence of renal protection, allowing us to continue with appropriate therapies for longer. Now, in the last few slides, I just want to mention some data that's recently become available in preserved heart failure. So the data we saw recently, the last few slides were in HFrEF with an ejection fraction reduced below 40. We're here looking at patients who have HFpEF, which is an ejection fraction above 50. This is a much commoner heart failure, but is associated with many more comorbidities. In this group of patients, there is much more respiratory disease, much more atrial fibrillation, much more evidence of insulin resistance. So the comorbidities are many. Regardless, up to now in HFpEF, there has been very little data of medications to reduce hospitalization of heart failure or CV death. And here we are looking at data with empagliflozin in HFpEF for the primary endpoint of CV death or hospitalization of heart failure. And you will see that there is a relative risk reduction of 20%. This risk reduction occurs really almost immediately the therapies are commenced, just the same as they are in HFrEF. If we then look at this potential of first heart failure, as we've discussed, this may be a surrogate for primary prevention. If you look at the right-hand panel, you will see that the first episode of HFpEF in the trial with empagliflozin is reduced by approximately 30% relative risk. So this again gives you an emphasis that there is an early involvement in the pathophysiology of HFpEF, potentially preventing or delaying the time to the development of first episode of hospitalization for heart failure. Now, it's important to try and compare the effects of the SGLT2 classes in HFrEF, ejection fraction below 40, and HFpEF, Emperor preserved, with an ejection fraction above 50. So here you can see the two set of results. And the striking feature here is the similarity of the results. you will see the hazard ratio reduction of composite CV death and hospitalization of heart failure by 25% in both trials, the time to first heart failure by approximately 30% in both trials, and the time to recurrent and hospitalization of first and recurrent heart failure reduction by approximately 30%. Important to note that when you look at CV death alone, you do not see a benefit in these two studies. So there is a similarity in the results, which reiterates, therefore, the potential pathophysiology of this benefit. Now, in the 20 minutes or so that I had, I could not cover the mechanisms of this benefit, and I'm sure that this will be covered through the course of the next 2 or 3 days. So what is the benefit in terms of patients? How does this translate for us in clinical practice? And here you will see that in the right-hand panel, that you have to use these therapies in very few patients for a very short duration of time to achieve the benefit that's accrued. So these are cost-effective, patient-effective, patient outcome effective, very effective drugs to use in heart failure. So how is this changing the ethos behind the management of heart failure? And the guidelines are now changing completely, whereas previously we had a stepwise approach. And now the guidelines are telling us that all 4 therapies, beta blockade, mineral receptor antagonists, RAS blockade, or ARNI, and SGLT2s should be initiated simultaneously at the diagnosis of a heart failure, and thereafter therapies should be increased according to tolerance. Now, if you do this, what you see is this benefit. So here we have the relative risk reduction of each of the classes of the therapies: ARNI, beta blockade, MRA, and SGLT2s. But the top part of it is if you have no therapy, the 2-year mortality is 35%. If you have quadruple therapy, as we have just mentioned, the mortality is reduced to 10%. So a huge effect in this group of patients. So in my last slide, in terms of renal disease, this group of therapies seems protective at all stages of renal disease, from prevention of development as well as progression and renal death. From the heart failure perspective, it improves cardiovascular outcomes, primary cardiovascular endpoints in HFrEF, primary first admission with development of HFrEF in people with or without pre-existent HFrEF, with or without diabetes, with or without CKD, and regardless of baseline therapy. And finally, we also have positive results with HFpEF predominantly related to hospitalization for heart failure. So in response to the question I posed early, who in type 2 diabetes should have these therapies when? I would suggest that all patients with type 2 diabetes should have an SGLT2 inhibitor in their therapeutic regimen. If you're not on an SGLT2, you should be on one. Thank you very much.
Thank you, Dr. Vora. It's an excellent review of SGLT2 inhibitors. Dr. Vora, we know, is a professor of Royal College, Liverpool Hospital, and he's a very skilled and experienced clinician and teacher, and an outstanding orator. And very nicely you have dealt the renal and as well as cardiac protection with SGLT2 inhibitors. I think it's a molecule of last decade that has revolutionized the treatment of diabetes as well as the protection from the cardiorenal point of view. So progression of cardiovascular disease, renal disease is one of the very important parameter in diabetes. So thank you very much. If there are any questions, Dhruvi, can we?
So there are no questions yet in the chat box, but we have a different discussion session allotted for 15 minutes at the end of the whole session after all the speakers are talking.
So thank you, Dr. Vora. If you are available for the discussion, we'll have in the last. And it's an excellent lecture, and you have talked very nicely. The CVOT brought all these two molecules, SGLT2 and GLP-1, that have been benefited in diabetes with all complications, renal and cardiovascular complications that are more important. So thank you. So nice of you. Thank you so much.
Thank you very much. Pleasure.
So our next speaker, Dr. Eberhard Stent, he'll be talking on heart failure, role of diabetologist tackling a multidisciplinary problem. This is a very important topic because diabetologists also have a responsibility of tackling the problem of cardiovascular and heart failure. So we are very eager to listen. Dr. Eberhard is a professor of medicine, endocrinologist, past president, IDF Europe German Diabetic Association, past vice president, European Association of Study for Diabetes and International Diabetic Federation. So thank you very much for sparing your valuable time. So we go on for a talk by Dr. Eberhard.
Good afternoon. Good afternoon, and thank you very much. I'll do the technical things, sharing my presentation, which should be here. Okay, and this should be now on presentation mode. So you can hear me and you can see my slides, yes. Okay?
Yes,
okay.
Yes.
Once again, thank you very much. My name is Eberhard Standl, and as just mentioned, I'm an endocrinologist, but also an angiologist and fellow of the European Society of Cardiology. So I've been working in this interface between metabolism and vascular disease during a long time. And I'm very pleased to highlight heart failure with preserved ejection fraction, the role of the diabetologist tackling a multidisciplinary problem. And my task, of course, has become so much easier after the brilliant talk we just heard from Chit and Dvora. So I have disclosures in trials, lecturing, but also recent publications like Heart Failure at the Crossroads, Diabetology, and of course I will come back to those publications. Now, first of all, I think it's important in this context to understand the so-called common soil concept, type 2 diabetes, at the same time with cardiorenal complication. And the concept indicates that the same cluster of risk factors, this metabolism, insulin resistance, low-grade inflammation, oxidative stress, etc., actually is driving the development of type 2 diabetes, the manifestation, but parallel to that, at the same time causing damage to the heart and the kidney, and the two organs, of course, speak to each other, so there are a lot of potential for a vicious circle. But the most important thing, all can occur simultaneously. And this is also proposed in this recent novel unifying pathophysiological concept, linking hyperglycemia, free fatty acids, other risk factors like iron metabolism, I should underline, the antioxidant system, and lipid oxidation. And this induces so-called ferroptosis. This is a programmed premature cell death occurring at the pancreatic beta cell, driving diabetes, but also harming at the same time the cardiac cells, leading to cardiomyopathy, renal damage, nerval damage, retinal damage, and also bone damage. And on the right side, some pathways are indicated and opening new avenues of research, actually trying to manipulate this iron metabolism and overload and trying to really find new approaches to prevent those complications. Well, as we all know, and that has been mentioned before very often, cardiorenal complications are the first manifestation of cardiovascular complications in type 2 diabetes. And as you see across all the countries listed, the blue lines are the cardiorenal events, and they by far go beyond the red lines, myocardial infarction, peripheral artery disease, etc. But also the point is very, very early. In fact, it can be there at the diagnosis of type 2 diabetes. So it's very, very early. And if you have it, it means really very bad news. Looking here at all-cause death in conjunction with heart failure, your all-cause mortality is more than twofold increased. In cardiorenal syndrome, it's even threefold. And in terms of cardiovascular death, the figures are 3 to 4-fold increase of mortality due to cardiovascular complications. So it's early, and it means bad news in terms of premature mortality. This is a contemporary huge population from the UK. The interesting things are really the very high incident figures. They are telling us that 1 in 2 people with type 2 diabetes will be diagnosed with chronic kidney disease in their lifetime, so 1 in 2. So consider right now worldwide, the estimate for global diabetes is around 460 million. So we're talking here about 230 millions of people getting kidney disease, but in my context, also 3 out of 10. Now, this would mean the global burden, 150 million people out there which will develop, who will develop in the next years heart failure. So it's very clear that every doctor who looks after people with diabetes has to be aware and has to be part in trying to cope with this tremendous challenge. And here we see some more details. If you are starting free of that, these are the 50 and 60%, etc. I was talking about. But if you start with CKD, you see the high prevalence of heart failure in yellow, and also premature cardiovascular death. But if you start with heart failure, it's even 60% of premature cardiovascular death, and also 60% with kidney disease. So I'm not talking too much about numbers, but it's very striking in all the trials out there that prior myocardial infarction in cardiovascular outcomes trials occurring also correlate very closely with the development of heart failure. And as you just heard, it's usually defined as heart failure requiring hospitalization. So this is the ischemic contribution to heart failure in diabetes. But of course, it's also going far beyond that. There are specific factors, including also what we see in the context with kidney disease, both reduced GFR, and here we are looking at the risk of hospitalization for heart failure, which really correlates with impaired kidney function, but also with increasing albumin excretion in the urine, again, showing the close interrelationship between the kidney and the heart. And as we all know, the heart is able to speak to the kidney via the natriuretic peptide system. Now, first of all, this is something inducing natriuresis and diuresis by complex mechanisms at the kidney, but this can be measured and quantitated. And at the same time, the kidney will respond with activation of the sympathetic nervous system and also activation of the RAS system. So very early on, there is the induction of this vicious circle, but the opportunity here is that we are able to look for this increase very, very early. And it's important to understand that very often in diabetes, like here, the shortwave study indicates that the first abnormalities is so-called diastolic dysfunction. And on the left side in this pie diagram, you see some subgroups on that. So diastolic dysfunction. And this is very tricky often to really diagnose. And the recent guidelines actually tell us here on the right side, when we go for the subgroups, actually HFpEF is above 50 left ventricular ejection fraction, recently mildly reduced ejection fraction, 40 to 50, and HFrEF is below 40. And there's what's indicated here that increased increased left ventricular filling pressure correlates very closely with the rise in BNP. So we are actually able to pick up early, to sense early the development of left ventricular dysfunction. They also give you cutoffs here for NT-proBNP, which can be measured, has a longer half-life, and the active hormone BNP, so the 35 and the 125. And what's it's very important, of course, we always have to realize the differential diagnosis of heart failure, chronic coronary artery disease, hypertension, valvular disease, arrhythmia. Very often, absolute arrhythmia is a problem in that. And what's important to pick up early the signs and symptoms of heart failure related to breathing abnormalities, of course, in the resting position, but on exercise, but also looking at an increased neck vein distension, and also doing the hepatojugular reflux. So one is easy by very simple means to look into that. And what's also important that in the guidelines now, the ranking going for this natriuretic peptide measurements is very up on the list, followed by ECG and also already done with imaging. And in practical importance, the negative predictive value of those patients. If it's below that, it's very unlikely. The specificity is close to 100% that those people will have heart failure. So the new concept, the shift in paradigm, is now to narrow down the gap between current intervention, as just outlined by Professor Chitan Vora, to the time point of the earliest detectable changes. And this is biomarker-based, even before you definitely find major structural changes. So we have, on the one side, the clinical context, coronary artery disease, hypertension, which in diabetes, driven by cardiac and cardiovascular disease, lipoglucotoxicity, cardiac fuel overload, and renal glucotoxicity drive the heart across the diabetes risk continuum all the way to heart failure, hospitalization, and cardiovascular death. Here we have the specific diabetes aspect of cardiometabolic myopathy, cardiomyopathy, and the kidney, leading to fluid expansion. So there is actually an expansion of intravascular circulating volume, glomerular hyperfiltration, sympathetic nervous system overdrive, and hypertension. Of course, the diabetologist is always interested, what about glycemic control? And yes, in terms of heart failure, as you can see in this red line or range, it is a predictor. But as we all know, the disappointing aspect earlier with the so-called mega trial as listed here, including UK PDS, showed that intervention, at least in this definition used there, was not successful. So this was disappointing. On the other hand, looking from today, we understand probably the wrong drugs had been used. There was a lot of insulin with the potential of fluid retention. There was a lot of actually rosiglitazone, 90% in some of the trial were on rosiglitazone, and also a lot of sulfonylureas. And as we just heard, of course, in this context, SGLT2 inhibitors, and I have listed here, the trials are now the recommended drug. So the situation has totally changed in that. So in this context, looking or focusing on heart failure with preserved ejection fraction, you already have seen the major outcome here, heart failure, hospitalization or cardiovascular death, very significant 21% reduction. And what is very important also, the number needed to treat for that is around 60. So in this situation, it's a reasonable margin. It's much higher when you look at the numbers needed to treat in heart failure with reduced ejection fraction, where the numbers needed to treat are down to 20 or even below 20. So patient values are very, very important when discussing the benefits of these novel drugs here. And here, again, we see that this effect happens regardless of diabetes. So diabetes as such in HFpEF has no specific other outcome in relation to SGLT2 inhibitors. And down below, you also see the spectrum of left ventricular ejection fraction. And actually, it should be pointed out in Emperor preserved, including heart failure with mildly reduced ejection fraction. So this is the most striking group. But meanwhile, it's very, very clear that probably it's regardless ejection fraction where those SGLT2 inhibitors were. Okay, so if one looks at the meta-analysis, which gives you some different ranges, but a very clear picture of 22% reduction. And as very recently, there is the DELIVER study, and this is using dapagliflozin. We yet have to see the data, but according to the recommendations, the companies have to release the reaching the major outcome results first, so we know that a second study, Emperor preserved, but also the DELIVER study show the same thing. Now, what does that mean? And recently on this background, the guidelines in cardiology, this is looking at the American guidelines. Previously, we started to discuss with stage 3, symptomatic heart failure, but now the stage A. So this is aiming at risk for heart failure. People without symptoms or signs, no visible functional things, but this is based on risk factors. Hypertension, CVD, I showed you why, diabetes, obesity, and then to be on the alert for pre-heart failure. And this is using the BNP levels and also troponin if necessary. So that means we can start therapy much more earlier. And actually, SGLT2 inhibitors in this cardiology guidelines have the first major player, even before other drugs come in. But with the development, you maintain always SGLT2 in a holistic approach together with ACE. So you're doing the same thing together with beta blockers, but also mineralocorticoids in an antagonist as mentioned. And regardless of left ventricular ejection fraction, and there is the prospect of also another change of paradigm. So if we are so sure across the whole spectrum of ejection fraction, that means we don't need right away imaging. Of course, it's very well indicated, but we can start the prevention earlier, even without the full imaging demonstration of heart failure. And so this is a summary what happens in patients with diabetes Of course, if heart failure is known, it's a different situation. You always check for chronic kidney disease. If you start with the risk factors, then the BMP measurements together with echoes, but also ECGs are very, very important. And also silent ischemic heart disease is very important to be taken into account. And I would subscribe. Probably all of people with type 2 diabetes should be, if it comes to therapy with glucose-lowering drugs on an SGLT2 inhibitors. And in terms of the precision medicine, if you fail to reach targets, probably in combination with a GLP-1 receptor agonist. So what is the role of the diabetologist, endocrinologist in this multidisciplinary treatment paradigm? Assuring diagnosis of heart failure. And 90% or so of all people with diabetes are seen in primary care or by family physicians. So, of course, it's a huge load, but there are also very useful point-of-care measurements right now. So it is possible. Of course, it's some investment, but in the midterm range, the benefits outweigh by far the costs. Assuring compliance with the cardiologic therapy, addressing the appropriate cardiometabolic approach, including education, of course, and also helping people to do some reasonable exercise programs, which is helpful in heart failure patients, and then tailoring the appropriate glucose-lowering therapy, and cooperation with cardiologists and also nephrologists. So it's a huge challenge, a huge burden out there, 150 million people worldwide with this problem. And I hope this lecture was some kind of helpful in making progress in this area for the many people with diabetes. Thank you very much for your attention.
Thank you very much, Dr. Bajaj. A wonderful message given to the diabetologist that we must look in every patient of diabetes, possibility of heart failure, and we with the appropriate cardiometabolic approach, we must know at what stage of heart failure the patient is. Also, the relationship between heart failure and kidney disease, it is also very important to know about the renal functions, and we must take in consideration the advice of a nephrologist and cardiologist to treat a patient with a appropriate drugs which reduces hyperglycemia also. So it's really a great message to the diabetologist also that we must look for the cardiovascular problem and renal problem also with the diagnosis of diabetes or hyperglycemia. So thank you very much, Dr. Stender. Excellent deliberation. We are very grateful to you for your lecture, and it's really a wonderful message and a great message to the diabetologist. Thank you very much, sir.
Okay, my privilege and pleasure. Thank you.
So next, the last lecture of this session by Dr. Sarita Bajaj, who is a wonderful orator, former director and professor, head of the medicine department, MLN Medical College, Prayagraj, president of RSSDI, past president of RSSDI, president of Indian Thyroid Society 2022, and still she's there, founder, president of South Asian Federation of Endocrine Society, and Professor Sarita Bajaj oration 2018, she started in RSSDI UP chapter. She delivered several prestigious orations, established Diabetic Education Foundation, Prayagraj. Areas of interest are thyroidology, diabetic education, and growth disorders. She is a wonderful teacher and an excellent orator. Over to Dr. Sarita Bajaj. I think she is not.
Yes, sir.
Yes. But,
Today I will.
Yes, lecture is there. The recorded lecture is there. So we can start that lecture.
We'll be talking about the teeth reflecting our cardiometabolic status. This is a roadmap I'll be following from the oral manifestations to the correlation with hyperglycemia, the associated cardiovascular risk, association with microangiopathy, present some of our data and what should be the research agenda ahead. I have tried to list here all the oral health related conditions associated with diabetes. The common ones I have highlighted. Remember that all, of course, you may not even see all of them in some of the patients, but the majority of patients, if you question them, they would have one or the other of these complaints. In fact, just the other day, I had a patient who was complaining of alteration in the taste, very significant alteration. In fact, that was his major complaint of presentation, despite the fact that his blood glucose was well controlled. The other reason I'm not going through this list is because what I will be doing is showing you photographs which will themselves depict all these clinical features. So what are the mechanisms and interrelationships? It could be because of immune dysfunction, side effect of drugs, peripheral neuropathy, salivary gland dysfunction, low salivary flow and or increase in the salivary glucose levels, and oral candidiasis. So this is what healthy gingiva would look like, contrasted with periodontal disease. A brief introduction. Periodontal disease is the 6th most common complication, responsible for poor glycemic control and increasing CV risk. 22% of patients with diabetes have periodontal disease, which increases with age. It is a two-way relationship, and 15% more tooth loss than in individuals who do not have diabetes. Just to show you that poor glycemic control leads to macrovascular complications as well as periodontal disease. So on one side, we have the micro, the macro, and then a list of the oral complications, the very common ones. A two-hit model for the pathogenesis is shown here. So you have periodontal microbiota, advanced glycosylation end product activation, exaggeration and sustained inflammation, impaired repair, which leads to enhanced periodontal tissue breakdown. So just to go into a little more detail how diabetes leads to periodontal disease and tooth loss, I've highlighted the immune responses, involvement of the microbiota, cytokines, glycosylation end products. Poor glucose control leads to increase in the glucose levels in the cervix fluid of the gums. Growth of micro aerophilic anaerobic gram-negative bacteria. The function of the polymorphonuclear leukocytes is impaired. The host defense mechanisms are decreased, again leading to more of bacterial proliferation. Fat metabolism in patients with diabetes leads to increase in TNF-alpha, interleukin-1 beta, and decreases PDGF, TGF, and FGF. There's more of glycosylation products. Collagen cross-linking reduces the collagen solubility, repair, and replacement. So the end result is gingivitis, reduction in the periodontal tissue, tooth loss through increase in bone cement and ligament damage. A host of microbiota, including viruses, has been listed here. So now just to take you through some photographs, this is localized or moderate gum disease. Again, severe periodontitis in a type 2 diabetic. severe periodontitis in a 22-year-old man with poorly controlled type 1 diabetes, severe chronic anaerobic periodontal infection, enlarged gingiva in a type 2 diabetic, a gingival polyp here and here as well, severe periodontitis in a patient who has poorly controlled diabetes, who had responded initially, extensive bone loss, which is better visible in radiographs. This is a gum boil indicating acute infection. Implant, because of the implant, there is inflammation and infection. Dental caries may also be associated. A fissured tongue caused by severe hyposalivation. This is candida, this milky curd-like appearance. This is candidiasis of the palate and candidal-related lesion, that is denture stomatitis. Again, angular cheilitis. This is candidal-related. You can have recurrent aphthostomatitis, lichen planus, leukoplakia, and oral cancer has been described. Temporomandibular joint disorders may also be a manifestation of hyperglycemia. And if you ask the patient to open the mouth, don't forget to look at the foot. If there is periodontal disease, there may also be associated foot disease. So can we say it is a foot and mouth disease? Perhaps yes. Presence of periodontitis predicted a 2 times increase in the incidence of type 2 diabetes. This was a 2-decade follow-up. 5 times increase in the progression of A1C among almost 3,000 diabetes-free participants. So this is some of the data that I'll be showing you. Clinical measures of periodontal infection are associated with increased insulin resistance. The risk of elevated HOMA-IR is increased by 30%, and the status is associated with insulin resistance if the WBC count is higher, as well as a higher CRP. So this was the first study which highlighted the relationship periodontitis to carotid intima media thickness. So the odds of an intima media thickness of 1 millimeter were higher for severe periodontitis and moderate compared with no periodontitis. Again, the results here may indicates that periodontitis may play a role in the pathogenesis of atheroma formation as well as in CV events. Small study, 50 carotid atheromas, 72% of the surgical specimens indicated a bacterial content, and 44% of the atheromas contained at least one of the periodontal microorganisms, which I had highlighted earlier. What about mortality? Death rates from ischemic heart disease and nephropathy were higher with severe PD than in those with no or mild PD or moderate PD. It has been implicated as a risk factor for stroke and carotid atherosclerosis as well, because of the associated endothelial dysfunction in patients with coronary artery disease. Again, the two-way relationship that I was addressing earlier, microalbuminuria is increased 2 times, end-stage renal disease 3 times in diabetic individuals who have severe periodontitis, cardiorenal mortality 3 times higher. But note the silver lining that effective periodontal therapy would reduce your A1C by 0.4%. A small number of type 1 diabetics to evaluate the relationship between the severity of PD and control of diabetes, divided into 3 groups, good, fair, and poor, depending on the A1C. And the result was severity of periodontal disease increased with poor glycemic control. What about the effect of therapy? 30 diabetic patients received appropriate full mouth scaling and root planning with systemic doxycycline. Group B received no treatment. All the periodontal parameters, including serum TNF-alpha, and A1C was significantly decreased 3 months after the non-surgical periodontal therapy. A lot of studies are out there which are showing the effect of periodontitis on diabetic complications and incident diabetes. I'm not going into the details, just to highlight that yes, they're associated with proteinuria, the severity. So this is the study that I was referring to, which has been published in the Indian Journal of Endocrinology and Metabolism. We took 50 cases, they were selected, they had oral complications, and we looked at the oral manifestations and the associated micro and macrovascular complications. These were the oral manifestations, from periodontal disease to oral candidiasis, tooth loss, oral mucosal ulcers, taste impairment, halitosis, xerostomia and salivary gland hypofunction, dental caries, and burning mouth syndrome. So if we look at the blood glucose status, the fasting blood glucose was significantly higher in cases as compared to controls, as was the postprandial. The complications, microvascular complications, were significantly more. Cardiovascular disease was more in cases compared to controls. However, there was a significant association for neuropathy, retinopathy, and dyslipidemia. And I have listed the p-values here for neuropathy, retinopathy, nephropathy, cardiovascular disease, and dyslipidemia. So several oral complications are seen. Periodontitis, commonest association of oral markers in diabetes and microvascular complications, suggests that there is a significant association between the two. Subsequently, we published a chapter. Dr. Sridhar invited us in this textbook, Advances in Diabetes, Diabetes and Periodontal Disease, making the connection. Yes, there is a strong association with smoking and periodontal disease. It's a major risk factor. What about treatment? I have, yes, pointed out that significant improvement in periodontal clinical parameters, which correlated with reduction in the A1C levels as well. Again, very recent data from Japan that glycemic control is strongly associated with the number of natural teeth, and this is in the real world setting. They've shown a continuous relationship between A1C and the fasting plasma glucose with the number of natural teeth. Their data emphasizes the importance of glycemic control and appropriate oral care for the protection against tooth loss. Individuals with impaired fasting glucose are at risk of tooth loss in middle age. So this is showing you across the ages the number of natural teeth loss, which are higher in individuals with higher A1C. This is the number of natural teeth age-wise compared when we look at the fasting blood glucose. The association between smokers and non-smokers in relation to blood glucose, fasting plasma glucose levels as well. So what they've tried to do is emphasize the importance of glycemic control, stopping smoking, and appropriate oral care for the protection of individuals with impaired fasting diabetes against tooth loss from a young age. This is just April 2022, not even a month-old article, which is showing the association between type 2 diabetes and tooth loss. This is a systematic review and meta-analysis. There was a positive association between type 2 diabetes and tooth loss in the cross-sectional studies. Type 2 diabetes increases risk of tooth loss by 1.87 times in unadjusted data and 1.2 times in the adjusted data. Pre-diabetes, I've been talking about diabetes. I did mention tooth loss in pre-diabetes as well. So even individuals with impaired glucose tolerance demonstrate severe periodontal inflammatory parameters. Severe periodontitis was associated with a 93% increase in the odds of impaired glucose tolerance after multivariable adjustment. Pre-diabetics with fasting more than 100 milligram and gingival bleeding are more susceptible to periodontal breakdown compared to those who have lower glucose levels. So the need to refer to an oral health care provider. I'm not going into details of the management. It is very well highlighted. And there are also some newer options for treatment as well. I would like to summarize by saying that the association between periodontitis and type 2 diabetes is bidirectional. 1/3 of patients with diabetes have severe PD. American Dental Association says that 1 in 5 cases of tooth loss is related to diabetes, macroalbuminuria 2 times, end-stage renal disease 3 times, cardiorenal mortality 3 times in those with severe periodontitis. Yes, you get a good A1C reduction with treatment of periodontal disease. Very few patients with diabetes visit their dentist regularly. They are unaware of the impact of diabetes on oral health and that diabetes can cause tooth loss. That implies for the healthcare providers as well. And diabetologists should refer their patients for a thorough periodontal exam, and dental professionals should keep a check on glycemic status. Oral health should be promoted as an integral component of overall diabetes management. So when we see the A, the B, and the C, the D is the dental checkup, which should be every 6 months. So there are future directions because yes, there's always need to do more. I would end by saying that I have tried to show you that your teeth reflect your cardiometabolic status, and this is what healthy gingiva look like. Pink, firm, should not bleed with brushing or flossing. Thank you. Thank you very much.
Yes, Dr. Dhruvi. Last lecture by
Yes,
Dr. Sarita Bajaj. So she is not present. So wonderful. It's a very clinical lecture and a very important from hygiene point of view. So can we have discussions now? Do we have questions?
None as of now, not in the chat box. I'll just communicate with the RX team in the meantime, sir, if you can take up some.
Yes. Dr. Bora?
Yes, sir.
Can I ask? Yes. Sir, do you think that the clinical inertia of starting early start of SGLT2 is very, very important to decrease this inertia? Because still the clinicians and diabetologists are not aware about the benefit, cardiorenal benefit of SGLT2. So is it because of clinical inertia? Because now there is no cost factor. The cost has come down in India to almost nearly around sulfonylurea. So what do you think, sir?
I think there are a number of reasons. One is that the data hasn't got through as clearly as it can. It is beginning to now and is beginning to gather momentum. Two, there has always been this issue about safety, particularly when the type 1 information started coming out and people said, oh, well, there's this issue about ketoacidosis, and in the past there has been issue about bladder cancers, fractures, etc., which of course we now know are not an issue. And the third thing is that we have spent a lot of time, and a lot of us lecturing today are guilty of this, trying to say, is it GLP-1 receptor agonists or is it SGLT2s? In my opinion, majority of the patients are going to need at least 3 drugs, if not more. And so it's not a question of which you should be using. It's a question of adding in SGLT2s to everyone. Now, so those are the 3 big things, in my opinion. The other part of this is there has been an emphasis on the MACE reduction of between 14 and 18% with the GLP-1 receptor agonists in a cardiovascular established enriched population. But what we have not emphasized at all is that with heart failure, increasing heart failure, you're increasing your cardiovascular mortality. With increasing renal impairment, you're increasing your cardiovascular mortality. You know, we know from the UK PDS that if you go from normal albuminuria to microalbuminuria, your cardiovascular mortality doubles. And then if you go from micro to macroalbuminuria, your cardiovascular mortality doubles again. So if you are able to reduce that development and reduce the progression, you are giving a cardiovascular benefit. So whilst we talk about organ benefit, the emphasis of the organ benefit in reducing the cardiovascular mortality has not been emphasized. So I think those are the major reasons that I feel the SGLT2s and GLP-1 receptor agonists have not been taken on. Of course, the issues about inertia with GLP-1 receptor agonists are slightly different and may be changing as oral presentations become more available. But I do think that those are the three things. One, the data hasn't got out. Two, people have been worried about side effects. And three, we have spent a lot of time arguing about SGLT2s versus GLP-1 receptor agonists, which come first, which comes after metformin, et cetera, et cetera. These are, in my opinion, passé arguments.
How common about urinary infection or fungal infection, which is said to be quite common in those who are using SGLT2 inhibitors? How commonly do you see?
So the meta-analysis all shows that there is a 0.4% increase in genital infections. Now, when I speak to my general practitioner colleagues, they tell me this is not a difficult problem for us to resolve. One, it's talking about public hygiene. It never happens in people who are generally very, very clean or take their public hygiene safely. Two, that even treating this is not a particular issue for us. So there is undoubtedly a small rise. It's an early rise because it's when the glucose level, the hyperglycemia levels are high, but the level of mycotic or genital infections or perineal infections declines with time as glucose levels become controlled. And my GP colleagues tell me it's relatively easy to control. So in my experience, telling the patients, you are likely to lose 3 kilograms in weight, this is going to give you good glucose control versus the small possibility of an increase of a perineal genital infection. I've never had a patient who says, doctor, I don't want those medications.
Right. So
I would like to make a brief comment.
Yes.
Sorry. Specifically when it comes to heart failure and cardiovascular death, we have looked into that, for instance, in the TACOS trial. And most of the time, it's acute sudden death. So it's a very specific complex you are talking about. It's not the typical cardiovascular myocardial infarction or this type of thing. So it's acute sudden death, which you are preventing. And of course, this impacts largely also on the mortality. And for that, the numbers needed to treat are very, very useful. They are down to around 20 patients you need to treat at those with heart failure, with coexisting heart failure, to prevent one acute cardiac death. And so in my mind, this is a very significant progress for that. But it's also true if people have a prior myocardial infarction. For instance, people in DECLARE TIMI have looked into that. So if you have a prior myocardial infarction, especially within the last year, you have a very significant reduction of MACE. So it's always the context, the comorbidity, when those drugs are working. But again, if you have a patient, and very often the distinction is made, go for a GLP-1 receptor agonist for arteriosclerotic cardiovascular disease. So the combination, when you really combine that, is really also adding in the benefit after or secondary after first myocardial infarction.
Thank you, Dr. Eberhard. I think Parik sir just got busy somewhere. Thank you very much to both of our speakers. And any closing remarks before we close the session? We are very much on time, and we are in the last almost 1 minute for the session. Any closing remarks from Jiten sir and Dr. Eberhard?
The SGLT2s are becoming the statins of this year. Use them and use them early.
Thank you, sir. Thank you.
Well, I would echo this. SGLT2s are a great gift of diabetology to cardiology. So this drug really has go far beyond diabetology. And for instance, it's now the number one and first drug in those people at pre-stage heart failure. So it's really a changing paradigm in that.
Thank you.
Very correct, sir. Actually, in CVOT trials, we were looking for a cardiovascular safety, but these two molecules were really revolutionized the treatment. We got these two molecules, which have been hijacked, I can say, by nephrologists and cardiologists for their benefit. Now, it is being more used for in cardiology practice and nephrology practice. Thank you so much, sir.
But that is why we need to talk about early use.
Yes, early.
We as the endocrinologists, diabetologists need to be talking about early use before they become heart failure or have established renal disease.
Try to emphasize.
But then we have to increase the awareness among and reduce the clinical inertia for more use of SGLT2 inhibitors. I think still the use of SGLT2 inhibitor is much less what we expect. So the most important thing is to, as Dr. Eberhard said, that a diabetologist should also think about the cardiovascular and renovascular problems. They must evaluate initially when a patient comes to you for the treatment of diabetes. Initially, I think at that time we must evaluate for his cardiovascular and renal problems, baseline, so that we can in future we can look after for those things. Thank you very much, sir.
From an SGLT2 perspective, you should be on one if you're not on one, and for the practicing clinician, the question should be, why not?
Why not? That's right. Why not? Correct. Why not to use? That's very right. Very right. Thank you so much, sir. Thank you. Nice.
Wish you a good conference.
Thank you. Thank you so much.
Thank you.
So
Bye-bye.
this session now?
Yes, sir. Yes, sir. We are just... Yes, we have the next chairpersons also. So thank you so much, Parik sir, for chairing this wonderful session. Thank you to our speakers, and thank you, sir.